Good evening, everyone. Dr. Srabani Ghosh Zoha ma'am also and all the aspirants. We'll start the class. Today's topic is annular erythemas, and the speaker we have here is Dr. Srabani Ghosh Zoha, who is a renowned expert dermatologist and cosmetologist in Apollo Multi Speciality Hospital, Kolkata. Thank you, ma'am, for being with us. You may take over.
Thank you, Sana, for the kind introduction. Hello and good evening, everyone. Today I'm going to talk about annular erythemas. Annular lesions are extremely common, and I'm sure all of you must have seen, and they do have a striking similar appearance. But sometimes it can be very misleading if you don't know the diagnosis. The term annulus means ring-shaped lesion. They usually appear as circular or ovoid lesions with the erythematous border, and sometimes there is central clearing. So before I go to the actual presentation, just a short introduction about the layers of skin. The skin consists of an epidermis, where you have this various layers of the skin, and here we have these Langerhans cells, which are the immunologic organs of the cell of the skin, and in the dermis resides the hairs, sebaceous follicles, and we have this fat, blood vessels, and the nerve receptors, which are responsible for our sensory perception. And skin offers not only protection to our body, but it occurs, it is an organ for thermoregulation. It does have immunologic responses. It is a barrier to the water loss. It causes secretion of the waste materials, and of course, last but not the least, is the organ for sensation. And also, you should be familiar with these morphological terms. Macule is a flat lesion which is less than 1 centimeter, whereas a patch is a lesion which is more than 1 centimeter but it's not raised. A papule is a small raised lesion less than 1 centimeter. A plaque is a raised lesion more than 1 centimeter, whereas a nodule is an elevated lesion which is quite indurated. A vesicle is a small fluid-filled blister less than 1 centimeter, whereas a bulla is a larger lesion measuring more than 1 centimeter. You should be familiar with this term. When we describe the skin lesions, we always use these terms, and also for your MCQ purpose, these terms are. Now, annular erythema can present in term, but rather it's a descriptive term, which means that spreading erythematous lesion. Here you can see there's arc-like lesion, then it can be polycyclic, when many cycles are joined together. They can have this gyrate appearance, or there can be a clear-cut border. So the morphology varies from, depending on the diagnosis and patient to patient. So the causes of annular lesions could be infection, which can be bacterial, fungal, there can be many kind of infections which can lead to this annular lesions. It can be inflammatory cause, granulomatous disease, connective tissue disease, eczematous lesions, and drug induced, and last but not the least, neoplastic lesions can give rise to this annular lesion. So let us look into the infection. Among the commonest infection, impetigo, you all have seen, but to start with, these lesions can present with this erythematous red areas. And in couple of days' time, then they start developing the pustule. So if you are not aware, then you might misdiagnose this. So if you are not sure about the diagnosis, it's always good idea to have a second look at the patient in couple of days so that you can make a better diagnosis. This impetigo is usually caused by staphylococcus or streptococcus. Then we have this tinea or superficial fungal infection. That is the one of the most common infection that we see in our day-to-day practice. And in a hot, humid climate, definitely the incidence is much more. The incidence of these infections are much more in diabetics, in immunosuppressed patients, and of course in low socioeconomic conditions. All these infections can proliferate because of the poor hygiene. Now, tinea, if they have this a pattern lesion like this, we call it tinea imbricata. It is usually caused by trichophyton infection. And nowadays, because of rampant use of topical steroids, we see these concentric rings. The central areas are being suppressed by steroids, and the fungus keeps on spreading, giving rise to this pseudotinea imbricata appearance. So whenever you see these patients presenting with this pattern, do ask about history of applications. Many of them will be using steroids before coming to the doctor. Now, and coming to the other infections, tuberculosis, again quite common in our country, and lupus vulgaris is a variant which presents as a flat erythematous lesions, and with time it becomes indurated like this. And if you press with a slide, you will see these tubercles, which is called apple jelly nodules, and this process is called diascopy. This represents the granulomatous lesions of tuberculosis. Now, I've classified other kinds of skin tuberculosis here for your benefit. So, it can be exogenous cutaneous TB, the tuberculous chancre, tuberculosis varicosa cutis, where they have a verrucous appearance, they look warty. Endogenous cutaneous TB, scrofuloderma, usually arises from an underlying lymph node or underlying tubercular focus. Orificial tuberculosis and some cases of lupus vulgaris. Hematogenic dissemination can happen with lupus vulgaris, gamma, and acute miliary tuberculosis. They also present with generalized erythematous, usually miliary means multiple rashes all over body. And we also have this tuberculid, which is an allergic response to tubercular infection. Hansen's disease or leprosy is another entity which you should know in our part of the country. Usually present as hypopigmented, hypoanesthetic plaque, but when they are in reaction, they can become erythematous, indurated, and elevated like this. And in borderline lepromatous leprosy, they can usually present with erythematous, indurated, raised plaques. And when they are in reaction, it is more red. And usually the patients have fever, joint pain. The lesions are very tender when the patients are in reactions. So when we start these patients on anti-leprosy drugs, because of this mycobacterial antigens that are released, because of the immunologic reaction, these patients land up in reaction. And also we have this erythema nodosum leprosum, which is a type 2 reaction variant. Again, after starting antimicrobial therapy, patients can come up with this lesion. Also, without medication, also sometimes patient can present with erythema nodosum leprosum. This is a type 2 reaction, as we call, in Hansen's disease. So here, just for your understanding, I've made this, I've got this slide. This is tubercular leprosy, means the immunity is very high and the AFB count is nil. Usually you don't get to see lepra bacilli in this kind of patients. Whereas in lepromatous leprosy, the immunity is very low, and if you do a slit skin smear, which means we take some fluid after slitting the skin and look for AFB bacilli, these patients will be teeming with the bacilli. And in between, the immunity actually from across it goes down. So the bacilli counts go up across this spectrum. And the treatment for paucibacillary Mycobacterium leprae is paucibacillary multi-drug therapy, and for patients with more amount of bacteria, we use multibacillary multi-drug therapy, that is dapsone, clofazimine, and rifampicin. Erythema multiforme is another entity you all have come across in your clinical practice. The word erythema multiforme means multiform erythema. So they are not of same morphology, but if you are watchful, you can see at times this Irish lesion, which gives a ring-shaped appearance. These are quite hallmark or target lesion we call. This is quite hallmark of erythema multiforme. Now, erythema multiforme can be because of some a lot of bacterial infection. Actually, 50% cases of erythema multiforme are because of bacterial infections. It can be viral as well. Apart from this infection, it can be associated with collagen vascular disease. There can be malignancy. It can be drug-induced. So it is important to look for the cause, and if you can identify, you can treat the patient accordingly. Hallmark of inflammatory lesions in dermatology is psoriasis. Psoriasis initially presents with erythematous plaque, To start with, it might not be that scaly, but with time it becomes scaly. And if you remove this, if you scrape these scales, you can see bleeding points, which is called auspice sign. Psoriasis can be associated with arthropathy. Psoriasis is also associated with another phenomena, which is called Koebner phenomena. Koebner phenomena means whenever there's injury in this patient, the lesions can appear at the same site. This is an isomorphic phenomenon, and the other conditions where you get this Koebner phenomena is psoriasis. Other than psoriasis is lichen planus, vitiligo, verruca, molluscum contagiosum. Psoriasis can be very extensive. You can have gutted psoriasis, especially after streptococcal infection, and in chronic cases, it becomes the scaly raised plugs, which are usually localized in most of the areas, and it can be associated with arthropathy and nail pitting. Treatment of psoriasis involves topical treatments with coal tar, vitamin D analogs, calcineurin inhibitors, and then we have phototherapy, ultraviolet B, and we have this PUVA or Soralin and UVA treatment. And recently we have this excimer laser, which has been used in psoriasis, as well as we use this excimer laser in vitiligo. And systemic treatment is mainly with cytotoxics. Also, we have this acitretin, and this is a vitamin A analog retinoid. And aprilimus is a phosphodiesterase inhibitor, which has been used in psoriasis. Among the biologics, tofacitinib, tumor necrosis factor alpha, etanercept, adalimumab, interleukin-7 inhibitor, secukinumab, ixekizumab, and interleukin 12-23 inhibitor, ustekinumab, has been used in psoriasis, and these are available in our country now. Other inflammatory lesions, urticaria, again, another common entity. You see this in your day-to-day practice every day. Usually, urticarial wheals are evanescent, which means they don't last for long. In urticaria, when it is less than 8 weeks, we call it acute urticaria. And when it is more than 8 weeks, we call it chronic urticaria. Now, if these urticarial lesions are persisting more than 24 hours and they are leaving some marks, erythematous or hyperpigmented marks, think more than urticaria. It could be urticarial vasculitis. And on histopathology, it can show this vasculitic picture. This is a patient of 29-year patients of Graves' disease with hyperthyroidism, which presented with this urticarial vasculitic lesions. Now, how do you differentiate between vasculitis and chronic urticaria? As I said, in vasculitis, it will be more than 24 hours. Purpura, pain, hyperpigmentation can present. You can have systemic signs like fever, joint pain, arthritis, and other features, myalgia. Laboratory features can reveal raised ESR, CRP can be raised, there can be decreased C3, C4 levels, and histopathology can be supportive, and it usually doesn't respond to antihistamines, whereas chronic urticaria responds better to antihistamine treatment. Now, you must remember the causes of urticarial vasculitis. Of them, AC inhibitor is the commonest culprit in our day-to-day practice. So don't forget to ask this history of AC inhibitor in a patient who is having refractory urticarial vasculitis lesion. Then rheumatic disease can cause urticarial vasculitis, viral disease, and malignancies. They can all present with urticarial vasculitic lesion. So at times you have to look for the causes as well. Among other inflammatory lesions, we have this vesicobullous disease. Vesicobullous disease, again to start with, can present with erythematous annular lesions. But if you are lucky, with time they can develop these blisters or vesicles, which is definitely suggestive of a vesicobullous disease. Now here we have a 69-year-old lady who presented with extensive blisters and erosion on her trunk and limbs for past 2 months. Here you can see extensive areas of erosion, but the blisters are quite tense. They are not flaccid. She denies any taking of new medications in the last 1 year. On further examination, there was no mucosal involvement. Which of the following is the first line therapy of this lady? So first you have to decide what is the diagnosis. So how you decide? Definitely it's a vesicobullous disease, but look at the nature of the vesicles. Are they flaccid or tense? They are tense bulla. There is no oral involvement. There's no mucosal involvement. So definitely you have to think of bullous pemphigoid, because that is the most common diagnosis. Also we have linear IJ bullous dermatosis, but that is a bit rare. But of course one have to think. So first line therapy, oral ketoconazole is an antifungal. There's no role of antifungal. Coal tar is usually used for psoriasis, we just learned. Oral methotrexate maybe in case of refractory patients we do use. Mild potency, mid potency steroids again will be unable to manage this degree of disease. Oral prednisolone, of course, is the answer for management of bullous pemphigoid. So this lady have bullous pemphigoid, and you can see there is subepidermal bulla formation, and direct immunofluorescence shows deposition of IgG and C3. And ELISA will reveal anti-bullous pemphigoid in one BP 180 and anti-BP 230 anti-BP antibody, that is BP 230 IgG autoantibodies, and this can be diagnosed from the peripheral blood, and that can be correlated with the disease activity. So the treatment of bullous pemphigoid with topical steroids, when it is less, it's limited areas, systemic steroids, and adjunct therapy can be with cytotoxic drugs, and omalizumab can also be sometimes helpful if there is high eosinophil count. Rituximab, IVIG, they all have been used for treatment of bullous pemphigoid. Now, there's another 77-year-old gentleman who presented with this rash. Here you can see again extensive areas of erosions. There are vesicobullous lesions, and scraping from the skin shows these acantholytic cells, which means the nucleus is large. So immunofluorescence staining of a skin biopsy from this man showed intercellular deposition of IgG within the epidermis. So intercellular deposition within the epidermis. So previously it was subepidermal, and now it is in the epidermis. Which one of the following is the most anticipated diagnosis? Pemphigoid, we learned this is not pemphigoid. Staphylococcal scalded skin syndrome usually occurs in children, and also it can present in immunosuppressed patients with extensive areas of superficial erosion associated with staphylococcal or streptococcal infection. But here you have well-defined areas of lesion with flaccid bulla. Staphylococcal infection doesn't present with this kind of vesicobullous lesion. You don't never see any vesicobullous lesion. It's only erosion and scaling. Pemphigus vulgaris, yes, this is the diagnosis because you can see this flaccid bulla. This is hallmark of pemphigus, and this Zank smear that is scraping from this skin shows this acantholytic cells. Necrolytic migratory erythema is associated with glucagonoma syndromes. Again, it presents with areas of superficial necrosis, erosion, and erythema, mostly over limbs. It will never present with this vesicobullous lesion. And dermatitis herpetiformis usually presents with small grouped vesicles, mostly over the extensor aspect. It will again never present with such huge blisters and erosion. So the answer is bullous pemphigoid. The large surface of areas of body can be affected, and the mortality can be high without treatment. And mucosal involvement is very common at presentation, unlike bullous pemphigoid. And the area of disease, there are two keratinocyte. In between the two keratinocyte, you have this desmoglein protein, which is at fault in pemphigus. That's why it loses the cell adhesion, and there is acantholysis of the cell. So the immunofluorescence staining of the skin biopsy directed against the keratinocyte desmogleins, and these autoantibodies results in loss of cell-to-cell adhesion. And as I said, this is called acantholysis. Pemphigus is also known for this Nikolsky sign, which means if you spread the skin over the adjacent to the bulla, it actually erodes the skin and spreads the bulla. This is called Nikolsky sign. It is also positive in staphylococcal scalded skin syndrome, toxic epidermal necrolysis. treatment of pemphigus is with high dose of steroids. Recently, rituximab is doing wonder for treatment of pemphigus vulgaris. So pemphigus and pemphigoid, these two are often confused. So in pemphigus, you have flaccid bulla, where you have tense bulla in pemphigoid. There's mucosal involvement in pemphigus, whereas it is rare in pemphigoid. It is intraepidermal pathology. This is subepidermal pathology. An autoantibody directed against desmoglein 1 and 3, and this is BP 180 and BP 230. And diagnosis is by histopathology and circulating autoantibody. Coming to the connective tissue disease, subacute cutaneous lupus erythematosus is a photosensitive disease. It's a subtype of cutaneous LE, and it can be associated with SLE, Sjogren's syndrome, or it can be drug-induced. And usually, mostly it's drug-induced, and these are the group of drugs which are responsible for subcutaneous lupus erythematosus. And usually half of these patients will actually fulfill more than 4 of ARA criteria, but usually their disease is mild. And if you stop the medications that is responsible, can sometimes resolve the disease. Here I just want to mention about neonatal LE, because you will be dealing with patients with SLE, rheumatoid arthritis, Sjogren's, so they can have a baby who is born with this erythematous rash. So this is very rare. This is because of the transmission of this ROLA autoantibodies, maternal transfer to the baby. It can also occur in normal healthy mothers whose antibodies were undetected. And the main problem with this baby is that 80 to 90% have AV block within first 4 weeks. So it's important that you diagnose babies presenting with rash with over face, photo-exposed areas, as well as covered areas. They should be earlier. It's important to diagnose them early and treat if they have any carditis. And remember, neonatal LE is not SLE. This 41-year-old gentleman presented with lesions over the face for past 4 years. You can see a scaly hyperpigmented plaque, and the lesions usually get worse after sun exposure. He has no systemic complaints. Which of the following treatment option is most effective for this gentleman? I'm discussing this patient because it's almost what we just discussed is related to those category. So this lesion is in photo-exposed area. There is scaling and close. If you look closely, usually they have a follicular plugging. That means the follicles are very prominent. So that is very hallmark for diagnosis. This is discoid lupus erythematosus looks like. So oral itraconazole is antifungal. We don't need that. Low potency steroid won't be good enough to cure these lesions. Narrowband phototherapy or PUVA light therapy, of course, won't help because this is a photosensitive disease. So that are mutually exclusive. Oral antimalarials are the drug of choice for patients of DLE. So of course, he needs a sunscreen and potent steroids, calcineurin inhibitors, intralesional steroids we use. Antimalarials are the drug of choice, and oral corticosteroids are needed sometimes if they have a disseminated disease. So subcutaneous LE can be divided into acute, subacute, and chronic. In this acute group, we have SLE. In subacute, we have SCLE. And this chronic group, we have this DLE, lupus profundus, lupus tumidus, which have a more chronic course. But remember, chronic patients can also have features of SLE at times. So it's important you investigate all those patients for other features of SLE to fulfill the criteria of SLE. This is a 48-year-old man's legs present for a long time. These lesions are at least 14 months old and have received topical steroids and courses of antibiotics. The lesions have deteriorated and recently have seen the lesions are broken and oozing. So he had a 6-year history of diabetes and he has a dermatological surgery for skin malignancy over face 8 years ago. So which of the following is the most likely diagnosis? So given the history, of course, we have to think of squamous cell carcinoma, basal cell carcinoma, but a biopsy will, of course, decide the diagnosis. But Look wise, it's a more chronic lesions which have been quiescent for some time, only now it's oozing. So probably it's unlikely. Necrobiosis lipoidica diabeticum. Yes, this is the site for a diabetic patient with a chronic lesions which is not healing. That should be the diagnosis. Yours usually happens in children, presence as nodule or ulcer. Usually they are single lesions. Arteriopathic ulcers usually present with multiple painful ulcers over lower limbs. They don't form in such huge areas. And basal cell carcinoma, again, this is unlikely presentation, but definitely given the history, a biopsy should clinch to the diagnosis. So necrobiosis lipoidica is a disorder of collagen degeneration, and it's a granulomatous response. There's thickening of the blood vessels and fat deposition. The exact cause is not known. It is thought it could be because of diabetic microangiopathy. And necrobiosis is often mistaken for eczema. But remember, if your eczemas are not responding to steroids, you have to think twice and do a biopsy. And necrobiosis is usually typically painless. And here is a patient who have responded very well to UV therapy because we don't have much effective treatment for necrobiosis. So we try various things. So UV therapy has been effective in this patient. Now for your benefit, I have noted all the diabetic skin changes. Skin changes that occurs due to diabetes can be xerosis, rubeosis fasciae, limitation of joint mobility, increased chance of fungal bacterial infection, microangiopathy, and neuropathy. Conditions that are associated with diabetes: granuloma annulare, necrobiosis lipoidica, we just discussed, diabetic dermopathy, and there can be associated autoimmune diseases. You know that. This is associated with insulin resistance as acanthosis nigricans, with acrocordons as skin tags, obesity, hirsutism, seborrhea, acne. They can all be associated with insulin resistance. And complications of insulin therapy is lipohypertrophy, scarring, blisters, all those things. You have to remember when you are dealing with a diabetic patient. Now, annular gyrate erythemas. Gyrate erythemas, also known as figurate erythemas, are a family of related skin conditions that occur chiefly as a reactive process, and it represents a visible cuteness manifestation of a larger hypersensitivity process. Or it could be infection, it could be a neoplasm, and usually they present as I already mentioned, sarcinate, polycyclic, and arciform erythematous lesion with a tendency to spread. So these four are classically known as annular erythema, erythema annulare centrifugum, erythema gyratum repens, erythema migrans chronicum, and erythema marginatum. Now, erythema chronicum migrans is associated with ixodex tick bite. It's caused because of Borrelia burgdorferi. It has three stages: early localized, then early disseminated, and in third stage, in chronic disease, there is arthritis, there is neuropathic manifestations, and usually they present with a enlarging erythematous patch. More than 5 centimeters is thought to be significant according to the CDC criteria. If you are lucky, you can see the site of bite at times, and lab tests can change to the diagnosis, and it responds wonderfully to doxycycline mostly. You can also use amoxicillin. Now, erythema annulare centrifugum is usually can be idiopathic, but it can be drug induced as well. There can be arthropod bite, infection, systemic disease, malignancy can be responsible. So it's important that you check the drug history, and you treat the underlying conditions. This is a patient of lung SCC lung who have been associated with, who has been found to be having this erythema annulare centrifugum lesions. There are many patients which have been reported. So whenever you see such patients, you see such patients, look for underlying malignancy, especially in elderly patients like lymphoma, leukemia, and it's more common in women. And the proposed mechanism is that underlying malignant condition leads to formation of the cytokines or antigens that stimulate these cutaneous eruptions like this erythema annulare centrifugal. This is a patient who presented with sore throat, and a week later, the patient presented with this erythematous rash, and histopathology shows this kind of infiltrate. This is a patient of rheumatic fever. So this is what we call erythema annulare rheumaticum or marginatum. It is associated with 20% of patients of rheumatic fever, and this erythema annulare marginatum is thought to be one of the major Jones criteria, and it has been seen it is associated with more cardiac involvement, and it is a hypersensitive reaction to streptococcal antigen, and it responds to penicillin. Usually this is seen in children. Erythema gyratorum repens again is a rare, and there's a strong association with malignancy. It presents as a migrating concentric rings which are pruritic at times. They can have associated palmoplantar keratoderma, hypereosinophilia, aqueous ichthyosis. Aqueous ichthyosis, palmoplantar keratoderma are other markers of malignancy. So these lesions can also resolve with successful treatment of the primary disease. Now, coming to the granulomatous disease, sarcoidosis can have some specific skin lesions which presents with maculopapules, plaques, like this, plaques, subcutaneous nodules, or infiltrative scars. Scar sarcoid is one of the important things. So, whenever a scar is indurated, infiltrated, think not only of keloid, think of scar sarcoid as well. And also, sarcoidosis can present with erythema nodosum. These are the other type of sarcoid lesions you can see here. And erythema nodosum, you all have seen that painful nodular lesion, mostly limited to the lower extremity, but definitely it can occur elsewhere as well. So these are the other dermatological manifestations of sarcoidosis I have just enumerated for your learning. Now, lupus pernio presents as raised indurated lesions of the skin, often purplish in color, and this is pathognomic of sarcoidosis. And lupus pernio is associated with high rate of intrathoracic, upper respiratory, ophthalmic. There can be bone cyst, there can be reticuloendothelial involvement. So whenever you see lupus pernio, think of severe sarcoid disease. And Lofgren syndrome is erythema nodosum, bilateral hilar lymphadenopathy with John's symptom, and Hereford syndrome is sarcoidosis in fever, uveitis, parotitis, and Bell's palsy. So again, these are for academic learning. Now, granuloma annulare usually is another inflammatory condition that presents with asymptomatic annular plaque, and this border is very characteristic. They're very, thickened thread-like border, and if we do a biopsy, we can see palisading granuloma, and they're very refractory to treatment, and they can be associated with diabetes, as I just mentioned. Now, eczematous diseases can present in various shapes and size. You never know in what form eczema will present. They can present with this erythematous rash. You can see very nicely annular arcuate lesions, and one can start thinking of other causes, but unless you take the history, they can have history of atopy. They usually have a history of recurrent lesions, and the lesion can vary in morphology. In chronic cases, they become more lichenified. Lichenified means the skin markings are more prominent, they are more localized. Usually, in adults, they have certain areas which are more involved. So atopic dermatitis is a chronic inflammatory disease, usually because of the epidermal barrier, the defect in the epidermal barrier function, host genetics, environmental factors, immune perturbations, all are involved in causing this atopic dermatitis. So in acute phase, it is a type 2 mediated disease, whereas in chronic phase, it switched to Th1 response. So in children, any whole body can be involved. As the child grows, it localizes, and in adults, mostly over the antecubital fossa, hand, feet, and behind popliteal fossa. And also, it's worth mentioning about Kaposi's varicilliform eruptions in atopic patients. When they have herpes simplex infection, sometimes they can have severe eczematous reaction. But also, you will be able to appreciate varicilliform rash. So, this is called Kaposi's varicilliform eruption or eczema herpeticum. Treatment is with acyclovir. They respond very well. And also eczema coxsacum has been reported in especially in children, but again, this you have seen the lesions of hand foot mouth diseases, but when they appear in extensive areas, it is called eczema coxsacum. Now this is treatment of atopic dermatitis from baseline therapy. We usually climb mild, moderate, and severe cases. In severe cases, steroids are usually used, but phototherapy can be helpful. We sometimes use cytotoxic medications, and recently, dupilumab have been found to be very effective, though not available yet in our country. Dupilumab is an IL-14/13 inhibitor, so it inhibits this pathway and it inhibits this Th2 response, thereby blocking the acute exacerbations of the disease. Last but not the least, drug induced. Drug induced lesions can be in various shapes and size. It can be urticarial. You all have seen. You can have fixed drug eruption, which means every time patient takes the drug, there can be erythema around the surrounding area and the lesion becomes more darker. And of course, there are many drugs which can cause this fixed drug eruption. So it's important that you make the patient aware. Now, erythema multiforme major. As I described this erythema multiforme, you have this Irish lesion. When the mucosal surface is involved, we call it erythema major or Stevens-Johnson syndrome. And when the extent of lesion is more, then gradually called toxic epidermal necrolysis. When the sheets of areas of skin are destroyed with this drug action. And of course, this is a life-threatening condition. So cutaneous adverse drug reaction can have a latency. Remember, it can have a latency 7 to 10 days. Why it's not listening to me? It can have a latency from 7 to 10 days. Even it can be late as late as 4 to 6 weeks. So don't discard your patients that the patient is not on any medicines, why they should have the reaction. It's very important to find the drug history. The patient can present with malaise, fever, and upper respiratory symptoms. They can have rash and various shapes and size, and they can have concurrent areas of erythema, edema. And do check the extent of lesion. Do check for skin tenderness. If the skin is tender, you have to be very careful. It could be an impending toxic epidermal necrolysis. So these are the drug lists for toxic epidermal necrolysis and Stevens-Johnson syndrome. It's for you to learn. Now, cutaneous drug reactions can be type A, which is predictable because of drug overdose. And type B can be non-immunological, which is drug intolerance, and it can be immunological, which is type 1. Type 1 reaction is Ig hypersensitive reaction, where we have this urticaria, maculopapular rash, and angioedema. Type 2, we have this hemolytic anemia. Type 3 is vasculitis. And type 4 is delayed hypersensitivity reaction. We have this 4A, where we have maculopapular rash. 4B is DISH. DISH means drug-induced skin hypersensitivity. And DRESS is drug reaction, eosinophilia, systemic symptoms. 4C is Stevens-Johnson toxic epidermal necrolysis, and 4D is acute generalized exanthematous pustulosis. So here, all these lesions we call scar, severe cutaneous adverse reaction, that is known as scar. So first we have this Stevens-Johnson syndrome. I already mentioned you have erythema multiforme type lesion, which can be can have vesicobulous lesion along with mucosal involvement. And usually less than 10% of body surface area is involved. Most common and culprit is anticonvulsants and antibiotics and non-steroidal drugs, anti-inflammatory drugs. Treatment is usually with IVIG, steroids, cyclosporin, and recently we are using TNF alpha inhibitors. Now, toxic epidermal necrolysis, when more than 30% of the body surface area is involved, we call it toxic epidermal necrolysis. When it lies in between, we call it SGSTN overlap. So again, the anticonvulsants, antibiotics, non-steroidals are the common culprit. Treatment of toxic epidermal necrolysis is really tricky. You have to take care of the general measures. Among the drug therapies, cyclosporin, anti-TNF, uh, these days we use, and of course, steroids is a controversial topic whether to use or not to use. In DRESS syndrome or in DISH syndrome, there's widespread skin involvement, presence of erythematous rashes all over the body. Again, it's very difficult to differentiate the rash. They're all circular erythematous, so it's really confusing. There can be associated facial edema, which is quite diagnostic of this drug hypersensitivity reaction. Again, antibiotics, anticonvulsants, sulfonamides are usually responsible, and treatment of this condition is usually drug withdrawal, supportive care, and steroids are usually given for this drug hypersensitivity reaction, and it is thought to be associated with HHV6 infection. And acute generalized exanthematous pustulosis, usually patient presents with pustular lesion over flexural areas, cephalosporin, fluoroquinones, they are mostly responsible for these lesions. Treatment is usually withdrawal of the drug, supportive treatment. Steroids are very rarely used for this condition. So this type 4 hypersensitivity reaction, this is just for your understanding. In type 4A, monocyte is predominantly involved when we have this maculopapular rash, whereas in DRESS syndrome, eosinophil is the main culprit. And in toxic epidermal necrolysis, cytotoxic reactions are mediated with T lymphocytes, perforin, granzymes. These are all liberated. That causes necrosis of the skin. And in type 4, that is acute generalized exanthematous pustulosis, neutrophil is the chief mediator. That's why you get this sterile pustules. So treatment of toxic epidermal necrolysis, this is pathway of care advised by British Association of Dermatologists. Whenever the patient comes, you have to look for the this prognostic parameters called score 10, age more than 40 years, presence of malignancy, tachycardia, initial epidermal detachment more than 10%, blood urea more than 28, serum glucose more than 252, and bicarbonate level less than 20 are all associated with adverse prognostic factors. So score 10 more than 5 is associated with mortality. So it's very important you look into this criteria and you counsel the patient's party. And drugs used for toxic epidermal necrolysis are steroids, IVIG, cyclosporin, and biologics, mostly etanercept. So coming to the neoplastic and paraneoplastic skin lesions. Paraneoplastic skin lesions are usually lesions that are associated with malignancy. They present in various shapes and forms. They are usually triggered by the immune reaction to malignancy. Our body's reaction to the malignant cells that gives this skin lesion. So this is a 45-year-old lady who presented with this pruritic rash on her abdomen. These lesions now covered with over her whole body. So what you can see areas of erythema, you can see areas of necrosis which are very well defined. Which one is the most likely causative agent? This is a very difficult question, I must say, but this was actually a question. So that's why I thought I will tell this. So is it B cell? B cell usually present with non-Hodgkin lymphoma, and usually they are subcutaneous lumps or lymph node swelling. So they won't present this kind of skin picture. Mast cells, usually in mastocytosis, you have areas of erythema or hyperpigmentation, and if you stroke, there is dermographism. That means there is red erythematous rash develops. So here you can see this erythema are permanent and they're necrotic. So mast cell is out. Eosinophils again won't give this kind of reactions. Again, there will be urticarial rashes. T cells, yes, this is the most likely diagnosis. And neutrophils, again, this doesn't look like any normal skin infection, so you don't expect neutrophils. Also, in there's something called sweet syndrome, but there you have you need to see the vasculitic feature to diagnose that there you can have some neutrophil infiltration. So the answer is D, that is T cell disorder is mycosis fungoides. This is a cutaneous T cell lymphoma. It presents as pruritic eczematous rash, which is a pre-malignant stage, and it develops as telangiectasia and cigarette paper atrophy when the disease becomes old. And as the malignancy develops, nodular lesions appear and proceeds to become necrotic at places. As you have seen in the previous slide, you can see these areas of necrosis. These are very, whenever you see lesions like this, remember, most likely it's T cell lymphoma. So these can show T cell lymphoma can present in various ways. Is you can see erythematous rashes, and you can have dark patches on the skin. You can have raised, thick, indurated plaques, or they can present in this hypopigmented variety. A skin biopsy is a must for the diagnosis for any rash which is not improving with treatment. So classic mycosis fungoides is divided into three stages like patch phase, where they present with non-specific dermatitis, as I have shown in the picture, plaque stage, or in tumor stage. And Sézary syndrome is defined as erythroderma, lymphadenopathy, and circulating atypical lymphocytes. They usually present with erythroderma. This is a variant of cutaneous T cell lymphoma. Topical steroids, topical retinoids, topical nitrogen masters, Sorolin and light therapy, that is PUVA, total body electron beam radiation, they are all used for mycosis fungoides. And for systemic treatment, we have these retinoids, recombinant interferon alpha, monoclonal antibodies. All these things can have been tried in mycosis fungoides treatment. Now, this is again for your understanding. CTCL with indolent, this is the WHO classification. CTCL with indolent clinical behavior is mycosis fungoides, primary cutaneous CD30 lymphoproliferative disease, and primary cutaneous CD4 positive disease. And CTCL with aggressive clinical behavior is Sézary, adult T cell leukemia, lymphoma, extranodal NK cell T cell lymphoma, and all these are aggressive disease. Now, paraneoplastic skin syndrome, as I mentioned, they are associated with malignancy. These are the classical forms: erythema, gyratum repens. As you can see, I've already discussed this slide. Necrolytic migratory erythema, where you see this is associated with glucagonoma syndrome, which is a pancreatic islet cell tumor, and mostly it is characterized by irregular annular shaped eruptions with serpiginous border, erosion, scalding, but mostly over limbs, but it can happen in lower trunk as well. It is important to identify these diseases early so that you can look for some malignancy and the patients can be treated. Paraneoplastic pemphigus, again, patients, elderly patients presenting with pemphigus, do look for malignancy. Primary malignancy, it could be lung, stomach. You have to look for any malignancy inside in order to rule out this association. This is another case of paraneoplastic here. This is called Peace syndrome. As I mentioned, erythema annulare centrifugum is associated with this neoplasia. This is a patient of B cell lymphoma who was on remission for 2 years, and they presented with this EAC type lesion for past 1 year. So this paraneoplastic erythema annulare centrifugum is also called Peace syndrome. So an approach to erythema, whenever there is, we come across these patients, there's a great clinical variability of erythematous rash, a logical algorithm, clinical knowledge, histopathological diagnosis will help to arrive at a correct diagnosis. And therapy consists of treatment of the primary cause, sometimes anti-inflammatory, antimicrobial treatment. It might be possible to target special cytokines that are involved with this, special biologic agents in future in order to treat many of these diseases. I hope this algorithm will help you in future to at least make some of the diagnosis. Thank you for your time.
Thank you, Srabani ma'am. It's a wonderful class. So Dr. Arijit Ghosal has asked about what malignancy associated with erythema gyrata
Depends.
repents.
Usually bronchial carcinoma, stomach carcinoma, these are more associated with erythema gyrata repens. But if definitely don't stop at these two. Definitely you have to look for. There are other many reported as well, but these are the commonest ones.
And ma'am, another question is 10 recent treatment.
What? 10 recent
10.
treatment. Recent treatments, I would say cyclosporin, etanercept. These are the recent treatment that we are doing. Biologics, basically. And IVIG have been tried for long, but it's not 100% effective. But definitely cyclosporin, if other indications, there's no contraindication for cyclosporin, definitely we give cyclosporin first these days rather than steroids. And etanercept can also be given if there's no contraindication.
And then, ma'am, another question is how to differentiate between PACE and
Borreliosis.
borreliosis. Yes.
Borreliosis, usually there will be there will be history of fever. There you can have a history of travel. There will be history of tick bite. So all those things. There will be some, and there can be other systemic symptoms. And peace also, for peace, this is a specific entity associated with. Usually, you will be able to find some primary cause, but if not now, because it can precede, it can go on hand in hand. It can also come later. Even the disease has been treated. So you have to have the history. You have to look for for possible causes that malignancies that can be associated. So for peace you have to look for the causes, whereas in borreliosis you have usually have the history and it's a more acute onset. Okay. And gradually it increases, and as I said, more than 5 centimeters should be the according to WHO, that should be the criteria for diagnosis. And also you have the serological markers if possible, then that will clinch to your borreliosis diagnosis.
Thank you, ma'am. That's all about
As a
the
pemphigus lesion.
questions. And anyone have any question, you can ask.
No, there's another question. Different types of pemphigus lesion and respective treatment. Okay, pemphigus. When you talk about pemphigus is an epidermal lesion. So you can have pemphigus vulgaris, which is virulent. Then we have pemphigus foliaceus, which is more superficial scaling, and you do get blisters, but the disease is not that severe. You have pemphigus vegetans, where usually the lesions are over the intertriginous areas. They have usually verrucous lesions. So sometimes it can be associated with secondary infection, but they are very localized, pemphigus vegetans. Okay, so these are the main types of pemphigus you have. And then also you have an IgA pemphigus, which histological, immunofluorescence will be able to diagnose that IgA pemphigus. Clinically, probably you won't be able to differentiate which is IgA pemphigus, which is IgG pemphigus. Achha, how to differentiate skin lesions that are infective and non-infective? This is a very broad question, really. But gradually speaking, generally speaking, infective lesions are usually short. If there's acute infection, usually it's bacterial. Fungal can be indolent, and definitely this tuberculosis, Hansen's, they can be indolent infection. But as such, there's not one single test by which you can say this is infective and non-infective. So if it looks like it's a bacterial infection, if you go for a pus culture, or you can go for a fungal culture, and also the biopsy definitely is the hallmark for diagnosing any skin lesion.
Thank you, madam. Thank you.
Madam, good evening, madam. This is Dr. Ghoshal. I
Yeah,
would like to ask you one question.
yeah.
Which can you suggest a good book, a basic book for dermatology? Is Roxburgh a good one, or you want to suggest something else?
There's a
Just a
Fitzpatrick
good basic.
Atlas. There's a Fitzpatrick Atlas, which is I found very handy for quick learning, and especially when medicine oriented. There's a small. I
Okay,
can't exactly tell you the details off and out of my head now, but there's a Fitzpatrick
Fitzpatrick.
Atlas. There are two parts of book, and that's quite handy. And I can send it to Asif, and Asif can post it too.
Okay, thank you very
Thank
much.
you, ma'am. Thank you.
And
Yes,
Asif,
thank
was
you,
it
madam.
understandable? Was it too fast?
No, 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 no. It's a absolutely good lecture. So last 1 hour আমি তো পুরো স্ক্রিনে হচ্ছে হাঁ করে তাকিয়েছিলাম। It's a good, it's a very
দুটো
good.
করলে বেশি হয়ে যেত তো পিগমেন্টেশন করলে না মানে আই জাস্ট
হ্যাঁ।
ওয়ান্টেড টু ইফ ইউ ডোন্ট নো দ্য ডিফারেন্সিয়াল ইজ ভেরি ডিফিকাল্ট টু আন্ডারস্ট্যান্ড
Yes,
সেই জন্য আমি বললাম
yes,
ওটাতে
yes,
কনসেন্ট্রেট
ma'am.
করি
Yes,
পরের
ma'am.
বার মানে হাইপার হাইপার পিগমেন্টেড করে দেবো।
Okay. Thank you, ma'am.
ওকে থ্যাংক
Thank you, student.
Thank you,
Thank
madam.
you,
This
ma'am,
was
for your insightful and engaging lecture.
Thank you.
We wish to see you again soon.
থ্যাংক ইউ
Thank
Thank you.